Integrated care works by joining up care for people. That can be with professionals working together in the same place and talking to each other about the care they're providing for a person, or it can be through a single point of access. So this means that from the point of referral, the point that someone's needs are told to us, we look at their care in a joined up way rather than just in an individual service or specific type way. And that hopefully means they get a better response from the start and only have to tell their story once.
Some people get admitted to hospital when actually they don't really need to be admitted to hospital. And if we could provide more care for them at home and coordinate that care between various different agencies, so district nursing, social care, mental health and general practice, we could look after them safer in their own homes.
So a referral will come in, it will have a basic description of what their needs are. So there's lots of clinicians and practitioners, and they'll look at that referral and decide whether we could perhaps join up services.
We had a call. The lady felt she had to go to hospital. The OT was on call here with me from Rapid Response, and we actually both went out together. And so we had a nursing assessment and we had a therapy assessment, and we were actually able to keep that lady at home that night, liaise with the GP from the patient's house to be able to get a review from the GP the following day. Her pain relief was much, much better the following day when I spoke to her.
We hold what we call a multidisciplinary team meeting, or MDT meeting, where basically all of the services and organisations sit together around a table. So we might have social workers, nurses, community matrons, occupational therapists, physiotherapists, even psychologists, and we all sit together and discuss the people, and then our GPs will phone in, they listen to what we're doing, they'll feed in any concerns that they might have, and then we'll try and join the whole picture up.
Hello.
Hello Dr Stradlin, this is Andrea Killick calling from the MDT meeting.
Mr Bloom is an 87-year-old chap that's got early stage dementia. He's also got COPD and he's morbidly obese, so he has mobility problems relating to that. His wife Helen is his sole carer, and she often has to call the ambulance for help when he falls because she can't get him up because of his size.
Okay, that's lovely. I'm just going to go around the table now very quickly.
He's a very valid candidate for the Falls team.
Shall we maybe do a joint visit as a community matron and
sounds like
the
a very
OT?
good idea. Cause
In the example, you'll see that we discuss the person and all of their needs, including the support that the family might require or the carer.
I'm also just wondering about the wife and how she's managing with all of this.
When we go out to assess, I'll be assessing her as a carer as well, to see if she's got any support needs.
Looking at it from other angles, not just health and social care, which is traditionally how we look at it, but we're looking at things like voluntary care organisations and support groups, access to internet and libraries, how to stop people feeling isolated at home. Every week we have voluntary services.
We could refer them to Camberley Care. There's also Surrey Heath Carers, who...
Voluntary services add that different take on supporting someone and their life at home that isn't just about their health and social care needs. It's also about how engaged they are in community, and the evidence is now showing that those MDT meetings are really stopping people going into hospital.
Okay, that's lovely then. Thank you very much. Shall we bring back to the table next Wednesday for a review?
The single most important thing to me is that now people are referring people's needs and not worrying about what services they need to support them.